It's been an incredible 2 days so far, and we have the last but most exciting day ahead of us. The last 2 days have been filled with 31 talks on Thursday, 17 talks yesterday, and I believe it's 12 or 13 talks today. So we have a lot to be proud of. We've come a very long way in a very short period of time, and I'm so proud of our whole community for making us what we are today to really be able to advance transformative treatments for children and adults living with Angelman syndrome. So thank you all for everything that you're doing for our kids, and certainly our community is very grateful to all of you who are working so hard every day. So thank you to our sponsors. We have an unprecedented number of sponsors this year, and we could not get this incredible room filled and be at this amazing place and with such incredible people without all of your support. So I'd like to thank Keter Solutions, Quincy's Quest Foundation, Ultragenics, Roche and Genentech, Ionis and Biogen, PTC, Neurin, Ulysses Neuroscience, Safety Sleeper, Texas Children's Hospital, Ovid Therapeutics, Encoded, and PCM Trials. There's so many people that have made this day happen, and mostly I would like to thank the FAST Board of Directors, because without you guys, none of this would be possible. So I'm very grateful to you guys and the hard work that you put in behind the scenes and don't really get recognized for that. So our Board of Directors, thank you. If everyone could just put their cell phones on vibrate, just so that it's not disruptive to the speakers, and if you need to take a phone call, just please step outside. The Wi-Fi is dream big in lowercase letters, all one word. And again, this entire day is meant for parents, caregivers, and families to ask their questions. You're here to learn, to listen, and I always want everyone to remember and repeat that knowledge is power, and if you understand and you ask, you will not forget. And it's really important that you think about the questions you have. Don't be shy to ask them. If you are shy, text me and I will ask them for you. I'm not shy to ask any question. But you need to be asking these questions, because the decisions you're about to make over the next 5 years are for you and your child and your loved one. And that's very important that you are capable of making those decisions. So ask the questions, don't be shy. And with that, I would like to start by introducing a very special person, our keynote speaker, Dr. Wendy Chung. We are very honored to have you here today. She is very highly demanded, and the fact that she said yes when we asked is pretty incredible. Dr. Chung is a clinical and molecular geneticist at the Kennedy Family Professor of Pediatrics of Medicine and the director of the clinical genetics at Columbia University. She directs NIH-funded research programs in human genetics of neurodevelopmental disorders, autism, birth defects, including congenital diaphragmatic hernias, congenital heart disease, pulmonary hypertension, breast cancer. She's a national leader in ethical, legal, and social implications of genomics. She leads the Precision Medicine Resource in the Irving Institute and the National Organization of Rare Disorder Center of Excellence at Columbia University. She is in the Dade County Hall of Fame. She is a recipient of the New York Academy of Medicine Medal for Distinguished Contributions in Biomedical Sciences and the Rare Impact Award from the National Organization of Rare Disease. She's a member of the National Academy of Medicine and the American Academy of Physicians. She received all of her training at Cornell University, which makes me feel like that's why we get along, because that's our alma mater. I received all my training at Cornell University as well. And she did her PhD at Rockefeller University in genetics. She is the Liz Berry Kravis version of a force to be reckoned with, but in New York. She is really quite a powerful person who cares so very much about our kids that are rare. And she is here to talk to us today. The title of her talk is Rapidly Evolving Opportunities for Treatments for Rare Diseases. Dr. Kim? Forward. Laser.
So I'm so pleased to be here today. I hope you can hear me. As I talk about this, I'm trying to think about how we work together to de-risk this, to be able to make sure at the end of the day that we can get the right people into clinical trials at a time in their life where they're likely to be rapidly or most amenable to response. So that's kind of the take home at the end of the day. And as I'll talk about, one of the things that I'm doing, something called Guardian, I hope is being able to do that for Angelman syndrome for newborns. So to be able to identify newborns so that we're all prepared in terms of being able to get to the treatment. So as I'm doing this, I'm going to talk generally about neurodevelopmental disorders. Again, I'll bring it to Angelman syndrome as I get to the end of it, but to appreciate that this is really a very large landscape. And so I think about rare conditions, rare genetic conditions in particular, and whether it's neurodevelopmental disorders associated with epilepsy, autism, intellectual disability, cerebral palsy, spasticity, really all of these are oftentimes lookalikes, and it's oftentimes quite confusing. And I can say for parents, I'm a practicing clinician. For parents, it's quite confusing in terms of being able to see first symptoms, especially in a little baby, and trying to prognosticate in terms of what does the future hold. And so I frequently get questions in terms of what is my child going to be like in 20 years? What can I do now to make them be their best when they're 20 years old? And how can you give me specificity in terms of guidance and what's going to work? And increasingly, thankfully, are there opportunities for clinical trials that are going to be helpful? And is it worth it? Should I take that risk? Is now the time to do it? And within this, if we just look at individuals, for instance, that are delayed in their milestones, I can't give them that information they're craving. So it really starts with a diagnosis. So I'm going to talk a lot about what I think of as getting to the starting line. How do we get every child, how do we get every individual to the starting line so they know which race they're running and they can get that specificity as we go forward? And I do think of this, not that everything's genetics, full disclosure, but a lot of it is, and certainly as we think about treatments, a lot of our treatments are going to be focused. So as we started that, we started an ambitious program, which some of you know me for, something that was doing this on a national US scale for autism, something called SPARK, Simon's Foundation Powering Autism Research for Knowledge, realizing that autism is approximately 2% of the population, but it's extremely heterogeneous, with some people with profound autism, some people with Angelman syndrome, for instance, who carry a label of autism amongst their other labels, and within that, trying to understand how we could get to the specificity. And when we started this about 6 years ago, genetic testing was not nearly as ubiquitous, thankfully, as it is today, and so there were a lot of individuals who were being left behind without a diagnosis. I'll also say one of the things I care very passionately about is equity, that is leaving no child behind, making sure that everyone gets a chance to get to the starting line, and as we do that, realizing that we're going to have some challenges in terms of being able to do things equitably and make sure that everyone gets that chance. So part of the predication for SPARK is to be able to give some greater homogeneity to that diagnosis of autism. Everyone in SPARK, as an example, gets exome sequencing and a chromosome microarray. Some also get genome sequencing to be able to identify both the known causes of neurodevelopmental disorders as well as identifying new causes and being able to understand modifiers, other genetic contributors, and importantly, for anyone who might be interested here, the entire US-based cohort is recontactable. That is, everyone is engaged in longitudinal research. The entire cohort is open for study. If individuals want to be invited, for instance, to clinical trials, all of these individuals are in fact engaged and available for recontact. As we're doing this, and as we do this at scale, and I'll show you just a second, we have over 100,000 individuals with autism in the cohort currently. And as we do this and think about doing this at scale, the question becomes, again, how do we do all of these things at scale to make sure that we don't leave anyone behind? As we've done this, we've learned an awful lot about the biology of these conditions, about understanding the natural history. We've developed now, as I'll show you, individual cohorts for over 100 of these neurogenetic conditions. We have specifically not tried to duplicate anything of what FAST or the Angelman syndrome community is doing so that we didn't have confusion in the community, but for other, especially what I consider ultra-rare neurogenetic conditions, have been able to develop those cohorts, and those cohorts are actually international. And so in doing so, we have now hundreds of individuals with many of these rare conditions, some of which are even as infrequent as 1 in 100,000. So as we're doing this, we have what I call a sister study called Simon Searchlight, which is now each of these individual genetic conditions. In total, we have over 150 of these copy number variants and single gene disorders. And again, those individuals can be diagnosed through SPARK and then invited to come to a community that's more homogeneous in the sense of individuals with whom they can interact, researchers with whom they can interact, understanding the biology, understanding the natural history, and just now starting to think about clinical trial readiness for some of those conditions. As we're doing this, within the United States, if any of this is helpful, we have 31 clinical sites for Spark that are positioned around the United States. And as we've been doing this, we've also been setting up some of these to be clinical trial sites. And so with doing this, we have personnel, we have expertise, we have engaged participants, we have the evaluators, we have the equipment that we need for doing this. And so we're setting up the infrastructure, if you will, in the United States to be able to accomplish this for neurodevelopmental disorders. And you'll recognize many of those sites here. In doing this, as I said, we have now over 100,000 individuals, most of whom also have genetic data. Some of them have, as I said, longitudinal information over time. We're starting to collect EHR data as well to supplement what parents are providing in terms of information, even including, for instance, EEG data to be able to have biomarkers that we can be able to look at over time. And in some cases, especially with Searchlight, cell lines to make induced pluripotential cell lines that have allelic series with corrections so that individuals for preclinical trials can be able to move those forward. These are just some examples of the types of evaluations that we do within Spark, and you can see that, again, these are related to various different things in terms of the brain and behavior. They're all standardized instruments, and we try and do this because we're very respectful of families and how busy they are, being able to prioritize things that are going to also be helpful for them. And as part of that, we think it's important to give back to the community, give back to those individuals who participate. So we give back genetic information, we give back results of standard evaluations, information that's going to be helpful moving forward. And this is a tool that we can use to learn together. And we very much believe that we need to learn together as we're doing that. I won't go into huge amounts of detail, but just to say that over the last year, there have been numerous very high impact publications using the Spark cohort and Simon Searchlight, identifying robustly now approximately at least 100 very high confidence genes and as many as 300 genes related to autism and related neurodevelopmental disorders due to de novo mutations. In addition to that, what we've also increasingly realized is that there are additional genes that can be inherited. And with those inherited variants, we also realize that those are associated with a wider range of conditions that is affecting the brain and behavior, and also in terms of population frequency, or in other words, the number of individuals out there, far more numbers, larger numbers of individuals than we saw before with some of the de novo variants. We also realize that there's a different biology that's involved in some of these new genes that are being identified. And one of the things that I think a lot about is what is our window of opportunity for treatability. And with all of these conditions, I don't think the answer is the same. And I don't have time to go into the hundreds of conditions at this point, but just to say that I do think each one of these is different and there are different opportunities with different biology and different opportunities for treatment. As we've done this, we've also realized, as I said, that it's not just autism, that although we ascertained the Spark cohort, for instance, with an individual professionally diagnosed with autism, we're realizing that for many of these inherited conditions, from parents from whom these are inherited, we're seeing also a range of things that are related to the brain and behavior, but other issues, whether they're attention issues, other problems in terms of depression, anxiety, in some cases bipolar disease, but other schizophrenia, other conditions that are related that may also give us insight into biological mechanisms when we think about a broader range of psychiatric conditions. And for this, I think we've got real opportunities going forward. So with this, as I said, we've developed this cohort, Simon Searchlight, which is international. This gives us many opportunities globally to have an impact. We have many, many strong family leaders working with us, and this is represented, and you can see all of this on the website. And all of this, I should say, any of the Spark data or Searchlight data or biospecimens are all freely available to any qualified researcher, be they in industry, academia, where this is meant to be able to de-risk this to make it possible for many people to do good research. As we're doing this, this is again longitudinal. We realize that we need natural history data to again be ready for clinical trials and clinical trial readiness. Different conditions have different associated problems, whether they be seizures, whether they be sleep disorders. But one of the things that we're also building within this, I think, are good measures that we can use for Angelman syndrome as well as across these. And I have to say, we've also borrowed from Angelman syndrome in terms of the ORCA as an example to be able to make sure that we've got consistency and And as, for instance, the FDA is thinking about from a regulatory point of view what outcome measures are useful, whether it be Vineland or ORCA or other things, to be able to have some consistency in the field. So as we've done this, we've also been thinking about hard outcome measures, objective outcome measures that we can use, so we don't have to worry about just a global clinical impression, but that we've got something. And again, EEG is something that we're investing heavily in terms of being able to objectively look at that and look at those changes over time, as well as things that we can do in terms of wearables, nearables, other things that can be able to get us the more fine and granular data, hopefully our greater sensitivity to change in terms of when we are doing clinical trials for many of these. So as I said, with this, there are some challenges about making this international. We've tried to respect internationally all the rules in terms of privacy and protections. We've built up the infrastructure in terms of speaking many languages and doing things in many languages, engaging our communities, whether in person or online, and as I said, building up our biobanks to do this. And with this, I think have had some success, although we're still improving. But just to give you a sense of the numbers and how this is increasing, even within COVID, when I know many clinical trials had difficulty, we've still been rapidly increasing in terms of the numbers that we have within Searchlight and being able to disseminate this information, as I said, freely. Let me just give you a couple examples of things that I think are especially relevant and somewhat surprising to me. One of the conditions that's named by one of our families as Jordan's guardian angels, or Jordan's syndrome, is due to a phosphatase, a mutation in a phosphatase. And as we were learning about this originally, associated, we thought, as a neurodevelopmental disorder, where children were delayed in their development. Some of them had epilepsy or seizures. And as we saw this, and this is important for those of you who think about therapeutics, for all of these conditions, one very interesting thing is the mutation spectrum that we see. And I obsess about this, I have to say, because there are some genes where it's clearly that the mechanism is haploinsufficiency, as it is with Angelman syndrome, although clearly Angelman's is a specific use case as an imprinted locus. But this was in fact quite different. And if you look at, for instance, the mutation spectrum shown over here on the right, you'll see very specifically missense variants. In fact, only one loss of function allele that we see. And again, you'll see recurrent missense variants. That is, even though these are de novo and these individuals are unrelated, we see the same variant over and over again. And in fact, if you start looking at the sort of a stick figure of the gene and look at the important domains, and I've shown this simply as a pile-up so that you can visually see where these variants are distributed, you'll see that they're not randomly distributed. And this is not as if it's a mutation hotspot where there's something that's going on within the genome at that individual, but this is something that is telling us about the biology. And the reason I bring this up is because we can now genomically be able to use large data sets to infer mechanism of action, and although it needs to be backed up by experimental data, we can start to put genes in different classes in terms of mechanism of action, be it dominant negative, where we might need to knock down an allele, something that might be changing specificity, in this case for this phosphatase, substrate specificity for the phosphatase, but being able to infer that so that people can informatically, I think of it as a hammer and nail. As you think about what your hammer is, what are the appropriate genes that would be nails as opposed to a screwdriver and a screw, for instance? How do we match those in terms of technology with the right genes for treatment? In fact, if you start looking at the three-dimensional structure of the phosphatase, and again, looking at the clustering of where we see the alleles that are mutations, we see clustering specifically within the binding site for the phosphatase, and again, it's not surprising that as we look at that protein and in fact how it changes dynamically, so as we see the conformation changes, all of those alleles that are pathogenic are within that same spot. By changing size and charge of those amino acids, we're changing the binding site and again the substrate specificity, which we can see from the phosphoproteomics. This is paired with being able to also look at the phenotype. And again, let me just show you one more time. There's several different alleles, and we see them with various different frequency. And one of the questions is, even when we think about designing clinical trials, can we think about all alleles being the same, and in fact, natural history of the entire cohort for the gene? Or might we even need to be able to get more specific in terms of alleles and think about natural history of specific alleles going forward so that we can, again, see that change over time? So with that, we've been able to do things that, again, within Simon's Searchlight are looking not just gene by gene, but even allele by allele. In certain cases, we have enough of certain alleles to be able to see some of those differences. And so I'm showing you just as an example some of the different phenotypes that we collect as we're doing this. We constantly learn and add as we need to. And it be they medical things that we're seeing, we can get quantitative measures, as I said, of seizures, EEGs, also things like vision and things that functionally impact many individuals in terms of gastrointestinal systems. And as we quantitatively look at something like a Vineland, and as we're doing this over time, what I'm showing you is broken down by domain on the Vineland and the scores on the y-axis, and then each one of these violin plots being a different allele. What you can see is that we do have differences by allele, that it isn't all one phenotype, and we also see that there's some variability even within one genotype. And one of the things that I personally give families a lot of credit for is that I have seen clinically a difference in what I call the cohort effect. That is that when I look at our individuals, for instance, with Angelman syndrome who are in their 20s, we have different outcomes, thankfully, than we do with individuals who are teenagers now, individuals who were diagnosed earlier and are now growing up and, for instance, in the 5 to 10-year-old range. And so as we think about clinical trials, I also think we're going to have to think about that cohort effect, because in a good way, we're doing better as we're figuring out what I call the care until the cure. So what we can do better in terms of care and improving educational strategies, improving treatment in terms of epilepsy. And so in a good way, this is a moving target. We're getting better just by our standards of care and being able to improve those standards. What was somewhat surprising to me, although perhaps I shouldn't have been surprised, was when, in fact, I was doing a neuropathology case on a 55-year-old gentleman who died of Parkinsonism. And the pathologist had asked me, Wendy, you know a lot about the genetics. He seems to be atypical for the Parkinsonism. Can you look at his genome and tell me if you can see something that might be responsible? And in fact, when I did that, what I was somewhat surprised to see is that he had the same exact genetic variants in the same gene that I'd been describing to you already. We simply had not been able to see the full life course of this condition. And that's true in terms of many of these relatively new neurogenetic conditions, where most people who are being diagnosed genetically are children or young adults in some cases. But they're certainly not individuals in general who are in their 40s, 50s, or 60s. When we did this, we were able, because it was a neuropathology case, to be able to see what was happening in terms of the substantia nigra, what we were losing in terms of neuronal loss, being able to see it both on MRI over time as well as being able to see the actual neuropathology and correlate that with the genetics. And since then, we've actually realized that this is not uncommon for this condition. We've documented this Parkinsonism multiple times. We've also been able, in a good way, to understand that it's DOPA responsive, so that this is really important for us. And as we've started looking at our cohort now and looking at the children and adolescents as they're aging up, we can already start to see the tremors and start to see the early signs even in the teenage years. And so by understanding this natural history, being able to understand better the biology, the cell types that are affected, we both improve the care by knowing that we have DOPA responsiveness in terms of this until we get to the cure, but also being able to realize that there are whole classes of genes that are not only neurodevelopmental, but also responsible for neuromaintenance, and without which we see neurodegeneration. And I actually think this is going to be a common theme that we're going to see. And as we think about the FDA and going to the FDA, there's definitely a different feeling in terms of what to approach in treatability and sense of urgency when we're talking about conditions that are neurodegenerative. And so again, when we think about that window of opportunity, for many of those conditions you might have thought simply as being neurodevelopmental and not having a window of opportunity anymore, I urge us, we need to understand the full natural history of these conditions, because I do think there are still opportunities and critical things that we need to do to sustain function for individuals going forward. As we've done this, and again, this is part of the care until the cure, one of the things that I was somewhat flabbergasted when I first realized it, because one of the family groups brought it to my attention, is that I assumed that ICD codes, as many people know, that we use for billing mostly, but ICD codes oftentimes in terms of our EHR trigger a lot of what can be done in terms of decision support. In other words, we have to not only have the diagnosis, but we have to see the diagnosis in terms of our clinical care. And I was somewhat surprised that we didn't universally have ICD codes for many of these rare genetic conditions, and was surprised in terms of understanding the process. But I will say that I think we have sort of windows of opportunity that are opening. The MED13L, which is one of these rare neurogenetic conditions, came to me and said, Wendy, we'd like to go to the CDC and be able to nominate our condition to be able to get an ICD code, and we want you to use that as an opportunity to understand how this works and to be an influencer with the CDC, to help educate them in terms of how critical this is for rare diseases and how critical it is for those of you who care for individuals with those rare diseases. Over a series of discussions with the CDC, I'm very glad to say that they're, I think, open-minded, a little bit overwhelmed, thinking that we have 7,000 rare genetic conditions all told, but I think open-minded to the understanding that it really does start with correct coding, and that going forward with that, as I'll show you, there's a lot that we can do in terms of dissemination of our improving and iteratively improving standards of care that we can use for these conditions. But I do think it starts with that diagnosis and with the right coding. And so I'm happy to say that just this week we in fact heard about the acceptance of MED13L to receive a code, and I think we now have the formula in terms of being able to move that forward. For any of you who decide to do this or want to support groups that are doing this, they do think about the medical impact, what actually changes in terms of clinical care for those individuals, what would you do differently based on now not just having a diagnosis, for instance, of epilepsy, but a specific gene that would go with it, be it Angelman syndrome, Dravet syndrome, whatever it might be. And I think when you make that argument clearly, they're very receptive to understanding that. At the same time, there's some of us in the community that are trying to make sure that these standards of care are iteratively updated and disseminated and publicly available in terms of open access. And I won't say that this is the only way that this is done, but gene reviews is something that we've provided in terms of infrastructure, and within this, being able to have this openly accessible to patients, to providers, to anyone in the industry who's working in terms of being able to think about clinical trial design, but it's one place where this is always available and up to date as far as we know it as physicians, as scientists doing this. And we've thought about how to be able to integrate that into decision support. And so increasingly with Epic as, again, one of the electronic health providers to a large percentage of the United States, at least in terms of thinking about this, with the correct ICD codes, with understanding and having peer-reviewed standards of care, how to be able to put that in decision support and be able to improve outcomes by having uniform standards of care for rare disease that are then on, I think of it as the highway of information where many people are getting their care. So we're developing methods with Epic that a provider, when they're in an encounter, rather than having to either go to gene reviews or dig or find this information, literally this information can pop up based on the age of the individual, based on what those standard of care guidelines are, be able to provide that information. So a busy provider, again, within that encounter can use their time most efficiently. And within this to be able to trigger what should be surveillance, what should be new opportunities in terms of clinical trials, for instance, new opportunities in terms of new FDA or EMA approved medications. And in doing this, I do think this is something that's going to help in dissemination. We've even thought about how to be able to make diagnoses when maybe they weren't made on the first pass through genetic testing. And as we're doing that, we're thinking about genomic data warehouses for individuals that get genetic testing. They may at first pass have a variant of uncertain significance where it's not clear that it's pathogenic or disease causing, but as the community has more information about interpreting those variants, being able to push out automated updates. So again, those individuals get to their starting line. They know which race they're running. As this goes on, even as new genes are identified that may not have been recognized by the clinical lab doing the data, again, if the primary data are available in a genomic data warehouse, we've even thought about the infrastructure that the research community can provide to be able to identify those new genes and conditions, be able to do that in a central way, and then distribute that and disseminate that back to collaborating centers that are doing that. And through organizations like the National Organization of Rare Disease and other things that we have distribution channels for being able to potentially do that. Within this, as I said, we have to build this really because we're not at steady state. We're still very much in the process of building the plane as we're flying it. And that's, I think, just where we've always been within genomics. And I accept that, and that's okay, as long as we build that infrastructure in place to iteratively update and improve. And so that's what a lot of this is about. Within this, though, it's also critically important to me that this is not just about providers or scientists doing this, but it's about families. It's about the individuals who directly care about this and that we empower them to be able to do this. So we've also been building with that interface in terms of pushing out not only to providers what the standards of care are, but to, in fact, parents, patients, family members who are involved in this so that they can be involved, engaged, and in fact are really the ones who are likely to implement this and to be able to get the work done. And so being able to do that broadly. Let me switch gears, though, to what I think is probably one of the more exciting things that we're doing and most directly related to Angelman syndrome. So some of you who know me know that in 2016, through partnership with the SMA Foundation and Cure SMA, we were at a very interesting time. If people can think back to what that was, we were just at the beginning of clinical trials with the ASO for Spinraza. And at the time, looking at the early data, I had been part of the Pediatric Clinical Neuromuscular Research Network, and so had seen a lot of our natural history data and knew, of course, that this was a degenerative condition. As we were starting and seeing the early data coming out of those clinical trials, I very much got the impression that because we had motor neuron loss and because we were identifying most of these patients by the time they were about 5 to 6 months old for type 1 SMA, by the time we were getting in with the ASO, we were having trouble being able to move the needle. We could sustain, we could maintain, but we certainly weren't making great strides in terms of improvement. And at the time, SMA, for those of you who know the genetics, know that it's a recessive condition, approximately 1 in 10,000 births, but 95% of individuals have a single common mutation. And so thinking as the molecular geneticist that I am, I said, you know what, we could diagnose that. We could diagnose that, and we could do that really for the vast majority of individuals. And so I came up with the somewhat crazy idea at the time of saying, you know what, let's try that. Let's try that with the newborn screen blood spots. Let's be able to make the diagnosis within the first 10 days of life so that we can identify pre-symptomatically those babies, especially with type 1, who would feed into those clinical trials, for whom we would likely see the best benefit, the greatest gains, and for whom, therefore, and it's a little bit of a chicken and the egg that I'll get to in a second, but for whom then we might be able to get a good medication over the finish line to approval. Now, the reason I said it was a little bit sort of heretical at the time is that the sort of newborn screening paradigm is that you have to have a treatment to offer newborn screening, right? And so there's a little bit of what's the chicken and what's the egg. If you can't get to a treatment because you can't diagnose it early enough, and you can't diagnose it early because you don't have a treatment, then we get stuck in a catch-22, right? So with this, I said, well, we're going to do this as a research study. It's going to be fully consented as we go forward. It's not going to cost anyone to participants to do this, but let's go ahead and try. As we did this, I'm very proud to say that with offering this in New York, we had 93% of parents who agreed that yes, they wanted to do this. We got the cost of testing down to 21 cents per baby, so we could actually scale this. We didn't miss any diagnosis to our knowledge in terms of doing this. And in fact, this is, I hope my video plays. This is one of our first children who were identified. She would have been predicted to have type 1 SMA. She would have been predicted not to live to 14 months of age, but these were actually home videos. And for those of you who know babies with type 1 SMA, they would not even be able to sit unsupported without having some effective intervention. So she was in fact, and of course it was offered, not forced or mandated, but she was offered to enter the clinical trial and chose to do so. In fact, went in, was one of the earliest in terms of age to go into the trial. And that same strategy in terms of the ASO, eventually the gene therapy, and everyone knows now the success story, is that based on these data, we now have 3 FDA-approved medications for SMA. We now have SMA added to the recommended universal screening panel in the United States, as well as internationally for many places, and we are almost at the point of full implementation in the United States, and we started that in 2016. So for me, in a relatively brief period of time, have gone from what used to be the most common cause of death genetically for children less than 2 years of age to, in a transformational way, being able to get every child in the United States the opportunity to live with this condition with a one, potentially, either one and done or one and at least a lot better in terms of treatment. And that's my hope and aspiration also for Angelman syndrome. So in thinking about this, though, again, I would urge early diagnosis was key. And I do think when it comes to all of the conditions I've been talking about, early diagnosis is key. And so I started thinking about what was next after SMA. And I can say we've successfully done Duchenne muscular dystrophy as another pilot newborn screening study. We've completed that, and you'll see that in press in just a few days, actually. And as I started thinking about that, I said, but you know what? This is too slow. I'm getting too old. I don't have, for each condition, if it takes 8 years to do this, 8 times whatever, like I'm long gone by the time we get through 7,000 conditions. So we've got to speed this up. And in doing so, we've set up now what I call Guardian. So Guardian is genomic uniform screening against rare diseases for all newborns. And as we're doing this, it's predicated in the same way. We use the newborn screening blood spot, but we do this on a backbone of whole genome sequencing to give us infinite flexibility of being able to look at any conditions for which we have treatment. And as we've done this with a partnership in New York City, as I'll show you, to be able to make sure this is diverse and inclusive and on scale. So the magnitude of this will be 100,000 newborns to be able to get enough for any one condition to prove that we can actually do this. It's complicated, so we start talking to individuals about this in the 3rd trimester. So while they're still pregnant, I want them to have the time to think about it, really decide if this is the right test for them, if they'd like to participate. And then we come to each and every person after they're born and talk to them about the process, allow them to decide if they want to do this, and give them up to 30 days after birth to decide if they do want to participate. Within version 1 of the test, it's about 250 conditions. We already have version 2 of the test, which will add approximately 250 additional conditions, including Angelman syndrome, I'm proud to say. And within that, be able to get these results back. Right now, our turnaround time is running about 4 to 6 weeks, but the eventual goal is to get it down to at least 3 weeks, and maybe even within the time frame of traditional newborn screening. And again, the idea being early diagnosis in terms of getting individuals to treatment. This is the demography of New York City in terms of our hospitals, and the wonderful thing about it is how richly diverse it is. It produces some challenges for me from a genetic point of view, but as I say, if we can do it in New York, we can do it anywhere, because we literally have the melting pot of the world within this, and so any of the things that we're learning here can be applied around the world as we're doing this. As we did this, we were in the planning stages with about 4 years in terms of thinking about this, and we've started with our families. We started with asking them, what would you want in this screening? Would you want this? And if you wanted this, what would you want within this? And we very much used and took to heart and iteratively helped them understand what the options were. And what they ultimately came to is, Wendy, give us things you're sure of. So things that, for instance, no ambiguity, no variants of uncertain significance, nothing like that. Give us conditions that are going to be essentially close to 100% penetrant by the age of 5, so things that will affect my child at an early stage, and things that there's something you can do. Even if it's not curative, as I'll get to with the neurogenetic conditions, something that we think will greatly improve the outcomes, be it epilepsy and treatment with epilepsy, early intervention, or other things. And so we have group 1 conditions, which I would call standard conditions like PKU, where we have extremely effective treatment, a la a cure right now. Things that I think in my mind I would say, well, of course, most parents would want to do that. And then we have the group 2 conditions, for which Angelman syndrome is one of them, where we don't have a cure right now, but we do think we're on the road to significant improvements. And we give parents the option of saying either do everything, group 1 and group 2, or just give me the core in group 1. As we've been doing this, and we've been doing this since a little bit earlier in 2022, I can say I'm very happy that, number 1, the test is validated, it's running very well. For those of you who know New York State, we're in New York State and work very closely with our State Department of Health. It's not trivial to get a test like this validated in New York State, so it took that alone quite a bit of time to do, but it's validated for all the conditions that we have, and as we've been going around to families, our uptake rate is about 75%, which to me is a good number in terms of Again, SMA was 93%. Not everyone necessarily wants to do this, and I'm okay with that. Choose your own adventure, and for parents, I want them to be thoughtful and make a good decision about this. But importantly, within that 75% of parents who decide to do that, 93% of those parents are saying, 87% of those parents are saying, yes, I would like to do those group 2 conditions. So as you start thinking about calculating what are the number of children that could be identified from this, what is the population prevalence of Angelman syndrome, and if you take 75% of that and then you take 87% of that, it's a really good number, I think, that we're going to have being available and ready for clinical trials. As we're doing this all with the idea that I am fully believing that we are going to have, with all of the people in this room, innumerable opportunities in terms of therapies that are going to come down the road. And again, I'm thinking about what can we do in a partnership to de-risk this, be able to make this easier for everyone to do the part that they need to do. I realize that different therapies are going to require different things in terms of where we can get to it in the body, what is the mechanism, what is the cell type we need to get into, do we need to get into every single cell in a circuit, or are there certain critical gene cell types that we need to get into. So thinking about all of those things, we've thought about things in terms of delivery mechanism and have many different things underway. I can say I even have personally N of 1 ASO studies that are going on for some of my ultra rare conditions, and so we're getting a lot more experience in terms of adaptive trial design and thinking about outcome measures that are very, very granular but much more sensitive, I can say, than some of the things I've thought about before, and literally on a daily basis learn from our patients and my families that I partner with in doing that. And I think we've got lots of opportunities in that way. As we think about this, and I'm glad for anyone who wants to grab me afterwards, I do think we've got some hurdles. I will acknowledge that everything hasn't been bright and rosy in the gene therapy space over the last couple of years, so we do have some hurdles in terms of some of our vectors, but I do think we also have some very good opportunities and some that are going to be coming down the road as well. And some, you all here, many of you know even more about this than I do, so I'm not going to go into a huge amount of detail, but I do think literally about categorizing different genes in terms of gene addition, when we need to do it, what we need to knock down, what we might need to edit, where our mutations are within those genes. Are they clustered in one place? Are they spread throughout the gene? So that as we think about this, and I'm glad to give anyone advice in terms of what might be a really good target for technologies that you have. So within this, I hope what I've been able to give you is some of the excitement in terms of opportunities going forward, because I do think we're doing a better job in terms of getting to the diagnosis earlier in that journey, potentially even within the first few weeks of life. As we're doing this, I do think we're going to suddenly realize that there are more people out there with these conditions than we appreciated. I think we've greatly underestimated the prevalence for certain conditions. I think we've also don't completely know the natural history, either because there's a wider spectrum in terms of what we saw before, either with individuals dying before they were diagnosed, or individuals who are milder who weren't diagnosed either. And again, as I said, over the life course, I think that's going to change. And in a good way, I think we're actually improving things, and so it's going to be a moving target. So I just want to thank everyone who's part of this. I'm simply the person who gets to travel and talk to you guys about all the exciting work, but it's really everyone behind the scenes, as well as all of our participants and our families, who really are the true heroes in all of this. So thank you.
We'll take time for a few questions. Dr. Weiss?
That's an amazing body of work. Thank you very much for sharing that. I have two questions for you. One is Angelman families here. Is it beneficial for us to enroll in this to get our kids sequenced? And because there's some crossover of autism and Angelman, and would that, if some of these genes are identified, would that allow some of these families with children to be coded for autism, because there's obviously great insurance benefits if that's possible. I don't know if that connection has been made yet. It seems like it's much easier to get an autism diagnosis in a very young child than an older child, so I wonder if you could comment on that. And then the other thing is a more broad question in terms of having a better understanding of the genetics of autism. Does that give you any insight into the cause of autism historically, this explosion in the number of autism cases? Are these things that were missed and never diagnosed? Has there really been this new growth of autism cases? And when you compare genetics to older people's genetics, are these new mutations that didn't occur before? Were they always there? Is it an epigenetic phenomenon? I wonder if you could comment on that.
Sure. So a couple different questions. One is that I try and make a clear messaging to families. And so we have diagnosed individuals with Angelman syndrome in Spark coming in with that autism diagnosis, and we try and redirect them actually to you all, because I don't want confusion in terms of messaging, and individuals' lives are crazy busy, and I want them to go to a place that's going to do the best for their data and the best for the research. And so it's not for lack of interest, and anyone who wants to come into Spark, I am thrilled to be able to give them any of the resources, data, anything else that we've got, but I don't want confusion for them. And so we can talk offline, but I'm still inclined to have them make sure they're like hardcore with the Angelman community and not get distracted by other things. The diagnosis is really one more for services. If an autism diagnosis helps in terms of getting services, then absolutely in terms of doing that, you should. That's in part the answer to your second question. And so I think the number of individuals getting an autism diagnosis has increased over time. For those of you who follow the CDC data, you know, the numbers keep increasing, and the question is it an epidemic? Is it something in the water or the air or something else? And really, I think what it is a reflection of, with that diagnosis, you get certain educational services that are actually very good, and so it's important for those individuals to get that care that they need and those educational supports. There probably is a tiny little bit in terms of reproductively. As a society, we're having children older, and it is the case that individuals there's a linear relationship between paternal age at reproduction and then de novo mutations, de novo point mutations. And so we have a very slight increase that we see as a result of that. And then at both ends of the spectrum, like I said, there are individuals for whom it's less stigmatizing to have the diagnosis, and so with the improvement of education, I think more people are being inclusive in terms of sweeping them in. But I don't think there's an epidemic of it going on out there.
Wendy is wonderful. I don't know how many times I hear your talks. Every single time I learn something new. So thank you. My question is specifically, you talk about the Guardian project. It sounds like you started enrollment already. And I do the quick calculation, 75 times 87 is 65. So it's a very, very impressive uptaking rate. Not just genetic research, any research. Yeah. So I want to ask if you can share a little bit, what's your strategy, how the consent will, and I assume that's in person. Can you get a little bit detail?
Yeah.
Thank you.
And I'm glad to talk with anyone offline. So like I said, we try, and anyone's welcome to go to the website. We have a we worked with families, I think is the key to doing this in terms of the messaging and what's the key information they needed to know to understand the study. So we've simplified it iteratively, and I think in that video have that well done. In terms of people that are approaching families, in every hospital we have people from the community that I think are relatable, are trustworthy, can explain it in language that's understandable, and I think that's been a real key, and I give them a lot of credit for being able to do this. And within this, I do think because we've done several other pilots of newborn screening, we have a lot of trust from our providers, our doctors, our staff, our community. So it's really with this experience, 6 years in the making, that's made it successful. I don't think we could have gone and just started it, from one day to the next and been this successful.
Question back there?
Hi, really great talk. So I know that in the field there's going to be a whole genome sequencing coming eventually for newborns. I'm wondering how you see that fitting in to what you're also doing and how they'll complement each other.
Yeah. So we actually had, in the first week of October, an international meeting of all of us that are doing something like what I spoke about in Guardian. Guardian, to my knowledge, and I think I'm correct, we're first out of the gate in terms of actually doing this and implementing, but a lot of individuals are taking our learnings and we're sharing them very freely in terms of for their studies, and they've already started pivoting and making some differences. So in England, for instance, there's going to be a very large version that's similar-ish, but it's going to be within the NHS, so there are going to be some differences. There are consortia across Europe that are evolving. We had a meeting with the French earlier this week, and there's a group in Australia. So it is starting to sort of bubble up around the world, but it's complicated, and so I'm happy to talk offline. I'm It is accelerating quickly in a good way, and for those of you who are in the industry, the cost of sequencing should be coming down significantly within the next year or so, which will also make this more possible to do at scale what I'm talking about. And so that was actually, with that knowledge in hand, was why I chose to do genome sequencing, so that we'd actually be able to, like I said, be infinitely flexible and know that the cost was going to come down over the course of the study.